Okay. Welcome, dear ladies and gentlemen, to the first webinar of 2025 for the Egyptian Representative Committee for the Royal College. My name is Dr. Sharif Solomon. I'm a consultant obstetrician and gynecologist, and I will be your moderator today. Today, we have an esteemed panel. They're here with us to discuss and inform us about the Placenta Accreta spectrum. As you're all aware, it's becoming such an extensive field, with every single one of us being subjected to it throughout our careers, especially with its current increase in prevalence, which is why we chose it to start the year off. To begin, we have a welcoming note from our chairman, Professor Yasser Abu Talib. He is the chair of the Egyptian Representative Committee of the Royal College, and he is also the chairman of the board of directors, as well as a professor at Ain Shams University, as well as a certified trainer in multiple international organizations, and he's obviously a fellow of the Royal College as well. Please, Dr. Yasser, Professor Yasser, please can you give us a nice introduction?
Thank you very much to attend this meeting, and I would like to just thank Dr. Sharif for his great effort as he spent a long time to prepare for this meeting. As well, I would like to thank very much our companies during this meeting, Professor Dr. Hudebi, Professor Dr. Ahmed, Professor Dr. Walid. They are going to introduce a very important subject. And by the way, we used it to select a hot subject to present it as a webinar discussing different way of management every 2 months. This webinar, we used to announce it long time before its presentation, maybe a month or 2 weeks before, and it's for free completely. If you want to join it, try to join it. However, if you are interested to see other webinars that we conducted before, you can go through our website, ERC-RCOG, and you will find a very nice website through which you can go through all our websites. It might be 6 or 7 webinars with maybe 30 sessions in different topics. As well, we are going to conduct others every 2 months. So try to join us and you will enjoy 100%. As well, you will find on our website the session that was conducted over the last meeting or our congress, which was held 11th and 12th of December. I would like to announce as well that we have many and lots of activity. If you are interested to join it, try to contact us to join it as well. So we have first many training programs. To start with, 2 hands-on training programs. It's Urogynecology course, a 3 days course, through which you can use your hands to do vaginal hysterectomy, sacrospinal fixation, urogyne operative intervention, and it used to be conducted by our colleague from England and from Egypt as well. As well, we used to have another course which is total laparoscopic hysterectomy, where we have 3 unique personnel conducting it. Everyone knows them. It's Professor Dr. Amr Husseini, Professor Dr. Gasser Bishri, and many professors from Egypt and from out Egypt as well. So it's hands-on as well for total laparoscopic hysterectomy. Infertility course, which used to be led by Professor Dr. Hassan Salam, and we used to invite Tariq Touhi, Iman, and Dr. Iman, who is one of the most famous one in Egypt for IVF, Dr. Abu Ali, and as well many persons with great experience in the field of fertility. However, we introduced a new course under supervision of Professor Dr. Sikitori and Professor Dr. Muhammad Hassan, who is hands-on colposcopy course and oncology course as well. As well, regarding to the members of the Royal College to improve their capability and to go through MTI, we used to conduct MTI training program to help them to have proper documentation, to introduce themselves to the college, to start working in England. as well physiological CTG course, robust course, emergency obstetric cases course, and third degree course, which is hands-on using pieces of bigs just to suture the third degree tear, and you will be competent as well. Operative vaginal delivery. So we have, as you see here, lots and lots and lots of training program, which we are very competent to introduce it in company in combination with our colleagues from England and from the MENA region as well. If you are interested to join any one of them, so you can contact our secretary, Jihan, or you can go through the ERC-RCOG website to register, or you can phone us at any time, and we'll be more than happy to support us. Our objective is to propagate a proper knowledge for everyone interested to have new knowledge and to improve his skills, knowledge, and attitudes to become very good in a training capability. By the way, looking forward to see all of you in our next meeting or congress, international congress, which will be held a little bit earlier than this year. It will be in September, 23rd and 24th of September. It will be held in Egypt. So waiting for all of you if you want to join us. And lastly, I would like to thank all of you again to attend this meeting and attend our professor conducting this session. As you know, that placenta accreta is now very common. And Sharif, I think he's going to introduce and tell everyone that we have a very, very, very big problem in Egypt for placenta accreta because of climbing up or the incidence for the cesarean section, which is sky high nowadays, reaching to 80% in Egypt. So I'm considering ourselves and especially our new generation, like Sharif, like Ahmad, like Hudebi, like Walid, are experts in this field because they used to manage maybe 3 or 4 cases every day. So they are highly experts. So I'm actually desperate to see what they are going to present, and we are looking forward to have more cooperation with everyone. Thank you very much, and see you soon. Sharif, would you mind to start? And thank you again for your great effort. Thank you.
Thank you very much, Professor Yasser. So starting off, Professor Walid Al-Basyouni, he's a professor of obstetrics and gynecology at Ain Shams University with an MD in obstetrics and gynecology. He's the lead of the Placenta Accreta Spectrum at Ain Shams University. He as well started the conservative management protocol in Ain Shams University, and successfully over the last 13 years, hundreds of cases successfully conserved their uteruses. He adopted the high-risk unit at Ain Shams University as well, that successfully managed these different cases and complicated cases over the past decade. Professor Walid, please start.
Good evening, all. It's my pleasure to be with you today. I know it's a weekend and everybody has other things to do, and I really appreciate that you took from your time to attend this webinar. I hope it's beneficial. I'd like to thank Professor Yasser Abu Talib for his kind invitation and for the effort he's been doing for the past couple of years, and for me for the past more than 15 years, because I've known him since I was a junior resident and he was a professor in the second unit, and all of his help and all of his efforts to help us throughout this time. I'd like to thank Professor Dr. Sharif Yahya for his efforts and for the coordination over the past 1.5 months to make this webinar come out in a good form in order to be beneficial for all of you. I'd like also to thank BGI, the sponsors of this session. I think they did a good effort, and thanks for their presence with us. So the lecture is going to be about a safe path outcome. We need to have a holistic approach for this. What do we mean by a holistic approach? We mean that we need to think about the condition or the problem from all its parts, because placenta accreta spectrum is increasing nowadays. let's say in the last, we've been starting to work upon it in 2010, so let's say 15 years now. Over the 15 years, the rate has increased markedly, and I'm thinking that the increase or the rise in the rate of placenta accreta spectrum did not come yet. Because in the next couple of years, I'm thinking that we're gonna so what we saw about the rate of cesarean section that is increasing worldwide, and in Egypt, as Professor Yasser said, the official numbers are 72%, and I think they are higher. We're gonna see a higher rate of placenta accreta spectrum definitely over the next couple of years. So this is a picture of one of the cases we operated upon in the year 2012. Which is 13 years ago. This patient, if you'd like to count the towels, there are more than 120 towels. So this patient lost around 15 liters of her blood. She took around 20 units of packed RBCs and fresh frozen plasma. She lived, of course. She did a hysterectomy, not to say, but of course she lived, and this was a success, a big success nowadays. So unfortunately, these patients are a ticking bomb. So when you see a patient like this, it either ends in a good way or it either ends in a bad way for the patient and for yourself. So placenta accreta, now it's called the bête noire. What is the bête noire? The bête noire is the black beast. The black beast of obstetrics nowadays is placenta accreta spectrum. Previously, when I was a student in medical school, the black beast of obstetrics was occipito-posterior position because we used to deliver a lot. And we used to have lots of vaginal deliveries. But now, because the rate of cesarean section is higher, so the black beast of obstetrics is the placenta accreta spectrum. So the current prevailing hypothesis is that's only a defect in the endometrial-myometrial interface, typically at the site of a prior hysterotomy or a cesarean section, which leads to a failure of normal decidualization in the corresponding uterine area. This allows extravellus trophoblastic infiltration and vellus tissue to develop deeply within the myometrium, including its circulation, and to sometimes reach the surrounding pelvic organs. And hence, the idea of the nomenclature that was previously said, which is invasive placenta, it's not a matter of malignancy or it's not a matter of invasiveness. The placenta is a benign, actually it's a very important organ for the baby, and all it wants to do is to supply the baby with enough blood throughout the pregnancy journey. So it tries to supply itself, it tries to invade or reach to a probable and a good blood supply in order to supply the baby with enough blood through the umbilical cord, the umbilical artery, throughout the pregnancy duration. This paper is very important because it carries a very high medico-legal issue that all maternal death related to placenta accreta spectrum are preventable. And actually, the numbers that most of the deaths are potentially preventable, and nearly 80% are avoidable by low to moderate complexity interventions. And hence, nowadays, with the litigations that are increasing, if anybody saw this paper and you did not take the proper precautions while performing your procedure and went to a litigation area, whether over here, like say Niaba or whatever, and he put this paper for them and told them that you did not follow up the proper steps, I think you're going to be sued for not properly doing this procedure. So what do we want? We want better diagnosis, and this is definitive, and we want better surgical outcomes. The better diagnosis is we want to reach a better incidence of pre-operative or pre-delivery diagnosis that this patient is placenta accreta spectrum. And when you diagnose that this patient is placenta accreta spectrum, hence you properly tailor the proper surgical maneuvers for this patient. This is not the patient that's going to be operated upon in your clinic. This is not the patient that's going to be operated upon in a primary care center. This is not a patient that's going to be operated upon even in a secondary care center. This patient needs to be operated upon in a well-equipped place, and I'm going to give you the criteria of this place that you need to work this patient in. And better surgical outcomes. Actually, the surgical outcomes is very important because there are a variety of maneuvers, whether radical as a hysterectomy or conservative. 15 years ago, when I started talking about this issue, Professor Ahmed Hussein, Professor of Obstetrics and Gynecology at Cairo University, he was with the surgical or the hysterectomy maneuver, and I was with the conservation maneuver. And we used to each other fight for his opinion and say that hysterectomy is the better opinion and conservation is the other better opinion. But when the years passed and the experience of each of us increased, the root of the surgery is not the important thing. I'm going to tell you lots of methods and lots of ways for the surgery, but actually when your experience increases, and this is an exponential process, because when you work a lot, you try to find better maneuvers and try to find better skills and try to find better ways to save the life of the patient. At first, most of the hospitals and most of the centers start by doing a hysterectomy, and then when their skills get much more better, they start to conserve the uterus, and then when the skills increase, they try to improve the methods of conservation of the uterus. So now actually we do not insist on which maneuver you work upon, whether the hysterectomy or the conservation, but put a system for yourself, put a method of operation, and with the increase of the number of the cases, you're going to find yourself doing the best for the patients. Actually, the condition is more than 120 years old. This is the first paper published in the year 1928 by S. Forster. He said that during a cesarean section, the placenta did not separate, and it was a case of placenta accreta, and he took the pictures for this condition. So it's not a recent condition, but of course, with the increase in the number of cesarean sections, the condition started to increase morbidly. So the rate of cesarean section is increasing worldwide. The mean cesarean section in developed countries is up to 25%, but as we said, in the countries that are facing this problem markedly, the rate of cesarean section is more than 50%. So in Latin America, in Asia, in Southeastern Asia, and of course in Africa and the Middle East, the rate of cesarean sections are high, and hence the rate of Placenta Accreta spectrum is going to be high. In Ain Shams University, we have nearly 14,000 deliveries per year. Although we have a weekly committee and we assess all the cases of cesarean section, we still have a 60% rate of cesarean section because we are referral centers and we are a tertiary center with nearly 700 cases of Placenta Accreta spectrum per year, representing nearly 8% of the cesarean sections. So although the impact of placenta accreta on pregnancy is well described, no randomized trials and very few studies have examined the management of pregnancies complicated by this disorder. And hence the placental advancement is a physical fact secondary to rupture of the myometrium. It's not a malignancy. And hence the insistence on doing a hysterectomy for this condition is not based on it's a malignant condition. But on the other hand, it's just a physical fact secondary to the rupture of the myometrium. If this fact depended on an invasive characteristic of the placenta, we would be able to see a similar percentage of invasions on all sides of the uterus, a phenomena which has not been observed to date. All the evidence seems to indicate that if a placental implantation adequately supplied with blood, the placenta only advances through the myometrial defect and it does not cause neovascularization or newly formed vessels, which are actually the main cause of uncontrolled bleeding. Because the neovascularized vessels, they don't have a uniform pattern, and if one of them bleeds, they don't have proper walls and you could not coagulate them properly and you need to ligate them, and this causes the massive blood loss because, as you know, at the time of delivery the blood loss is nearly 1 liter per minute. Management by a multidisciplinary team and delivery in a tertiary care facility improves outcomes and lower complication rates. This is the most important slide today because this patient needs to be operated upon by someone who is experienced in it. And even if the experience is not vast at the beginning, with the increase in the number of the cases, the experience increases exponentially. And hence, you need to properly assess this patient. I know that the practice in Egypt is a bit different and everybody likes to operate upon his cases because of the financial issues, but believe me, no money would compensate the problems that could happen from this case. So better criteria, ultrasound criteria. I think Dr. Ahmed is going to speak about the changing criteria of ultrasound and MRI, which is actually not important in the diagnosis of cases of placenta accreta spectrum. So what's my message for you as regards to the ultrasound? I don't want you to be an expert in the ultrasound, but at least if you find the placenta in the lower segment, if the placenta is near the cervix, if the placenta is covering the cervix, whatever you do a Doppler, whatever you see there's lakes of blood vessels, if you could diagnose that there's new vascularized vessels, this patient needs proper assessment. This patient needs a better ultrasound to diagnose the level of the placenta accreta spectrum, and it needs to be operated upon in a better place in order to give this patient the best outcome. As I told you, the MRI, the problem in the MRI is the interpretation of the pictures are not easy, and it needs a better expertise, and of course the cost and the availability. So some people say the MRI is just beneficial in cases with posterior placenta that you could not diagnose. So what about balloon catheterization and arterial embolization? Although many small series and case reports have reported use of catheters, it actually is not that beneficial, because when you occlude the internal iliac artery or the anterior division of the internal iliac artery, it actually shifts the blood through the anastomosis and through the external iliac artery, which fills the new vascularized blood vessel through the anastomosis with blood, and actually it may cause excess or more blood loss. This is a case we operated upon by the interventional radiology team in Ain Shams University. It was, the patient had the balloons inserted in the interventional radiology department, and then it was transferred to our department for a cesarean section, and the patient actually lost excessive blood, and she also had a hysterectomy, and it was not beneficial, and all of the papers say this also. As I told you, there was a debate about whether you do a surgical or radical hysterectomy or a conservation. The main issue about conservation is that you lose much more blood. This is a Acrreta study, which is a prospective study on the conservative management versus a cesarean hysterectomy, and the results was that among women with placenta accreta spectrum who underwent cesarean delivery, conservative management was associated with a lower risk of transfusion of more than 4 units of packed RBCs. Of course, it's operator dependent, and that's why I don't insist on doing a specific procedure. When you start working in a team and when you start increasing the number of your cases, your skills are going to improve, and then you're going to know how to manage these cases properly. Multidisciplinary team. I could not emphasize on this point much more than this, because now over Egypt I know lots of teams that have started working this case here in Cairo and in Aswan and in Luxor and in Minya and in El Fayoum and Asyut and Alexandria. Lots and lots of teams have been working, and I know them over the past 15 years, and I know that their skills increased and improved, and actually they made even new skills and new techniques for the management of this condition. So what is the criteria of the Center of Excellence? You need universal access to this team. You need a standard care plan, because you have to put a protocol for the management of the cases, whether based on the ultrasound or based on the skills of the team. You have to have a radiological expertise for the diagnosis, experienced obstetrician, surgical expertise for complex surgeries, anesthetists, neonatal intensive care units, adult intensive care units, massive transfusion capacity, and this is very important. Do not work in a place that there's no blood bank in it, or there's no capability of preparing blood with at least 4 to 6 units, and if you need more, you're gonna stop the operation because you did not have enough blood, or you're gonna just start packing the patient because you do not have enough blood. Additional surgical expertise when needed, and interventional radiology by your side. This is a comparison between the different guidelines. The FIGO 2018, it's going to be changed this year, the RCOG and the ISPAS, and a chosen recommendation for us. And actually, most of the recommendations are equal, that ultrasound should be the first line for the diagnosis of past disorders, and that you should properly assess and properly diagnose the condition before the surgery, and that the blood requirements should be prepared and should be ready for excess of usage. MRI is not essential. Scheduled non-emergent delivery is advisable between 34 and 37 weeks of gestation. The incision, whether a midline or a phanestoel, there's no difference. You should give the patient tranexamic acid. The role of bilateral internal iliac artery ligation actually is not important. As I told you, it shifts the blood through the anastomosis and the external iliac artery. The conservation still debatable when these recommendations were present, and hence, and again, I insist on that the conservation is not the target, but that the patient living is the target. Total hysterectomy is preferred over subtotal hysterectomy in cases of placenta previa or placenta accreta, leaving the placenta in situ with an option, although I don't agree with it, but it may be life-saving for the patient. If you're opening the patient in a place that's not ready and you diagnose it intraoperatively, just open away from the placental side, deliver the baby, close the uterus, and transfer the patient to a place where they could manage the placenta. And this is much better than trying to separate the placenta and the patient's gonna bleed markedly. The extirpative approach or forcible manual removal of the placenta should be abandoned totally. The use of methotrexate is not recommended because it works on proliferating trophoblast, and after delivery there is no proliferating trophoblast. Preventive surgical or radiological uterine devascularization is not recommended routinely for these conditions. The benefits from ureteric stents is probably limited also, and I tried several patients to insert a ureteric stent, but actually it's difficult to insert it while the patient's pregnant, and the benefits through the intraoperative procedure was not that high. When the extent is limited in depth and surface area, uterus preserving surgery may be appropriate, which is the conservative surgery, and it also depends upon the surgeon is going to do the procedure. As I told you, there are lots of governance in Egypt. We have 27 or 29 governance now, and the presence of a team in each government is very important. This paper was talking about the management of unexpected placenta accreta spectrum in resource-poor settings, okay? So you open the patient and you discover that it's placenta accreta. So what are the recommendations? Always look for a sign of placenta accreta spectrum in the anterior wall of the uterus in pregnant women. If there is a sign of PAS, avoid cutting through the placenta and extract the fetus through a fundal incision. Before such an incision, call for help. Ask the hospital manager for a formal support mechanism in the obstetrical ward or during surgery. Train easy and effective strategies to control pelvic bleeding. And the recommendations to the hospital: prepare a plan for massive obstetrical bleeding, define additional personnel to support the initial response, define a formal route for emergency transfer of pregnant patients. And number 4, this is a very nice idea: establish a formal telehealth process for severe obstetrical emergencies, including PAS. And this is a example for it. So you had a case, you don't know what to do in it, just take a picture or take a video and let one of the teams who are capable of the management and he's going to tell you, avoid this area, take this place, do this. He's not going to be present with you in physical, but at least his presence via telemedicine is going to be beneficial for this condition. A definitive decision regarding conservative management or cesarean hysterectomy should be made preoperatively, and this is very important. The delivery with a hysterectomy, you could do a vertical or a transverse incision. You should assess the place of the placenta in order to avoid cutting through it, and then you're going to deliver the baby and start doing the procedure of the hysterectomy after doing a bladder flap. So the hysterectomy is a bit easy, but what about the conservation? What is your plan to conserve the uterus, conserve the fertility, conserve the baby, or conserve the life of the patient? And this is very important. You have to put a plan. What's your plan? And what's your limit? When you're going to transfer or change your mind from conservation to hysterectomy. We had an approach for conservation, and it's somehow based mainly on controlling the bleeding from the patient. I'd like to just show you a very fast video of it. This is the patient, as you see. We have a placenta accreta with new vascularization, and the placenta is present, invading or covering the cervix completely. The main idea is proper dissection of the bladder, a incision through the upper edge of the placenta or through the placenta, delivery of the baby, and then trying of ligation of all the bleeders via support of the internal os or the cervix. Okay. This is a video also of the condition. Now we're going to opening through the upper edge. And now we're going to ligate and control the bleeders via small stitches that are controlling it through the internal os. And finally, this is the final picture where the patient did not lose more than 1.5 liters. She took 3 units of packed RBCs, and this is the final picture of the uterus. So the conservation or the radical surgery, it's not our issue. Cell salvage is very important. We don't have it frequently over here, but I think Mohammed Al-Hudaybi is going to speak about the role of cell salvage in patients and decreasing the number of transfusion of RBCs. What about the long-term reproductive outcomes following this procedure? Actually, we did a study on 50 cases where we did conservation, and we found that in these cases, nearly 45% or nearly 80% or 82% of the patients, there were no intrauterine adhesions, and there were 3 of them minimal adhesions that were dissected by hysteroscopy, and only 2 that there were defect at the anterior uterine wall. And hence, the post-operative fertility is not effective. To sum it up, ultrasound is the main line of diagnostic measures with a specific checklist that should be present. Refer to a center of excellence fulfilling the specific criteria. Operate upon these cases on an elective base between 35 and 37 weeks. Do what you are trained to do. Do cesarean hysterectomy is a safer procedure, and do not do a forcible removal of the placenta while you do not know the skills of conservation. The role of ureteric stents and radiologic intervention is still to be assessed. Trial of conservation must be in selected cases with expert surgeons. This is the Mohammed Al-Hudaybi and I were in the Congress of the Royal College 2019. We were presenting the conservative management of Placenta Accreta Spectrum, and I hope I see him again in London soon. These are the professors and colleagues and friends who operate upon the Placenta Accreta in Ain Shams University, and I owe each and every one of them a big role in preserving and helping lots of patients over the past years. And of course, we could not promote ourselves and could not improve ourselves without research and proper research. And this is mostly the Medical Ain Shams Research Institute, and it's one of the big institutes that had a big role in hepatitis C management in the last couple of years. Thank you very much.
Okay, thank you very, very, very much, Professor Walid. Just for reference, we will be answering all the questions in the end, so as to get as many questions as we can for our panel to answer. Our next speaker is Mr. Mohammed Al-Hudaybi. He is an obstetric and gynecology consultant with a special interest in complex benign obstetrics and gynae surgery. He's a member of the surgical team who deals with Placenta Accreta Spectrum at NBT in Bristol, where he has worked for the last 7 years. He has completed his advanced training in benign gynecological surgery and urogynecology. He has been a faculty member on a number of train-the-trainer courses for operative obstetrics, and before coming to the UK, he trained and worked in Egypt, where due to the obviously unfortunate high cesarean section rates, PASS was a common feature of the workload. His main areas of interest include complex surgery, improving patients' experience, and teaching. Mr. Al-Hudaybi, please go ahead. Your mic is off.
Thank you, Sharif. The technical difficulties as always. Thank you for your lovely introduction, and I'd like to thank Professor Dr. Yasser Abu-Talib and yourself for inviting me for this webinar. And I'd like to thank the rest of the panelists and the organising committee, and for all the attendees for taking time to attend this. My name is Mohammed Al-Hudaybi, and I'm a consultant obstetrician gynecologist at North Bristol Trust. I'm the lead PAS surgeon, and I've been doing that role for the past couple of years. I hope in the next 20 minutes I'll be able to share my experience as an Egyptian working in the NHS. PAS is the next obstetric pandemic. All the statistic modelling suggests that there will be an exponential rise, as Walid was saying, in PAD cases in the next few years. And the UK is renowned for its organisational capacity, and the NHS has always focused on the collective rather than the individual. And lots of international guidance have been produced in the UK. And I think another title that would have been completely appropriate for my talk today would have been how to organise for a safe PAS delivery from a UK experience. I do appreciate that some of this is resource dependent, so it's just please take as much of this as you can, and I'm happy to be contacted later if you've got any questions. So, as I said, I work in Southmead Hospital, and Southmead Hospital has a strong legacy of both patient-centered care and safety. We are the home for PROMPT, which is the multidisciplinary obstetric emergency training. And as I've mentioned, the Southwest Placenta Accreta Network. Let me just explain what that is. The NHS England has specially commissioned a group of clinicians in each region to oversee and deliver Cornwall, and that covers an area of 45,000 deliveries a year. There are other specially commissioned groups throughout England. The one that's closest to us is Oxford and then London. There is one that's set up by Mr. Ahmed in Wolverhampton, and one that's being set up currently in Birmingham. NHS England wanted to have the centres after maternal morbidity and mortality was shown to be 900-fold in placenta accreta patients compared to the basic maternal mortality in the UK. NHS England has set the criteria for what does it mean to be a PAS centre, and that means having a PAS surgeon, having an obstetrician with experience in major obstetric hemorrhage, having urology and vascular on site, having neonatology on site as well. It also speaks about facilities like having ITU facilities, having a blood bank, having NICU facilities on site. The main aim for NHS England by having those special commissioning, by the way, means that we receive extra money from NHS England to be the host for looking after those patients in a certain region. And the main aim for NHS England is for patient safety, and that is by reducing mortality and morbidity, reducing ITU admissions, blood products, and unnecessary hysterectomies, as well as midline incisions. Instead of boring you with our guidelines, I thought I'd bring them a bit more to life by following the journey of a couple of patients that we had, and we will be jumping from the journey to the guidelines and back throughout, so please bear with me. Our first patient is a 37-year-old patient who had 3 previous cesarean sections. She started her journey in Truro, and I'll explain where that is. And we were first alerted, the team in Truro were first alerted about her when she had her 20-week scan. And on the 20-week scan, she was found to have a placenta previa. For those of you who are interested in PAS, you know that the risk then of having placenta accreta with low-lying placenta and 3 previous cesarean sections sits around 40%. Then again, going to guidelines, although placenta localization in itself is not a recommendation of the fetal anomaly screening program, it still is considered good practice by NICE, and it is indeed a recommendation of the ERC-RCOG to localize placentas during 20-week scans. So this was the first time the concern of placenta accreta was picked up was when the patient had their 20-week scan. Most of the 20-week scans are done by sonographers or midwives, not obstetricians and not fetal medicine consultants. And so if a patient has 1 major risk factor or 2 minor risk factors, they are then referred to fetal medicine to have further assessment by a fetal medicine consultant in their local units. Most patients would be in the box on the upper left corner, which is 1 previous cesarean section or multiple previous cesarean sections and the placenta previa. This busy slide is our referral pathway for placenta accreta in our network. So basically, if a patient has 1 major risk factor, as I mentioned, or 2 minor risk factors, they are then seen by their local fetal medicine unit. If the fetal medicine consultant then sees on their scan at 24 weeks that there are signs of placenta accreta, they are then referred to the regional center, which is Southmead Hospital in the case of the Southwest Placenta Accreta network. So the patient, as per protocol, was then seen at 24 weeks by our colleagues in Truro, and they did indeed find some features of placenta accreta. They found myometrial thinning, subplacental and and UV fold hypervascularity, and there was a placental bulge. Interestingly, in this patient as well, and that just again, as Walid was saying, thinking about the holistic approach and other risk factors, this patient had a short cervix. Those are the signs that we look for in placenta accreta, and I'm sure Professor Ahmed Hussein will elaborate on that a bit more. We basically use grayscale ultrasound to search for loss of clear zone, myometrial thinning, abnormal placental lacunae, placental bulge, and the hypervascularity. And as part of the scan, we also assess for cervical shortening. The scan is done as an abdominal as well as a transvaginal ultrasound. Just to give you an idea, the drive from Truro up to Bristol is about 3 hours, and that is on a good day. So this patient had a scan, and this was the first time we utilized telemedicine. She was scanned in her local unit, and our colleagues from fetal medicine from our unit were able to direct the scan and to assess the patient live. She did indeed have the features that I mentioned. The patient was then referred to our MDT. And what happens, what's our mindset when we receive such a referral? Basically, we're thinking about four things. We want to confirm the findings, and that's either by a scan that is done in-house, or in this case, because of the facilities, we were able to do a telemedicine scan. Routinely, we use MRI, and as Walid said, the value of MRI is debatable. We sometimes use that to back up our fetal medicine consultants and to help with building the experience. We also want to individually risk assess the patient. So the patient might have different risks, as placenta accreta is a big family name that has multiple variants in it. So it might be a localized placenta accreta, or it might be a widespread disease. There might be involvement of the cervix. There might be other problems in the pathology, but also the patient might have other comorbidities, whether that's medical or surgical. We want to communicate our plan and make a plan with the patient and let the referring teams know and make them aware of our plan as well. We might utilize their help in various points, as I will show. It's very important that we continue to document and learn from cases as per clinical governance. Our multidisciplinary team has a huge number of clinicians and non-clinicians as well. The core group involves a fetal medicine consultant, myself as the surgical lead, an obstetric consultant, an consultant anesthetist, and our specialist midwife. There is representation from other team members as well. We have representation from the blood bank, we have representation from NICU, we have representation from theatres, so that helps and aids in planning. So when a decision is made, everyone's aware and multiple teams are aware, the blood bank is aware and the theatre team is aware as well. We meet regularly every 2 weeks for half an hour to discuss new cases and to reflect on previous cases. We usually want to document our plan in a preset performer so that we don't forget any parts of the plan. We aim to see the patient in a joint clinic so that we all are singing from the same hymn sheet and the patient receives the same information from all of us. It's important because they will have questions. What if then an early delivery is planned? What about the anesthetic component of the plan? What about the surgical plan? So we all see them at once. And we summarize the plan that we made in the MDT and later the plan that we made with the patient in a performer. We usually send patients specialized letters like the one that you have on the screen right now, saying that they will be either seen for a scan or that we have a planned delivery. And it's important because, as I said, we cover a wide geographical area to have plans for emergencies as well. What happens if a patient goes into labor or starts bleeding before the planned delivery date? We provide them with, we aim to provide them with information leaflets that we will be very happy to share should you want them. And because lots of the information, most patients wouldn't know anything about placenta accreta until they're faced by the diagnosis. So it's important to realize that they won't retain all the information that's given to them at the time. So we give them our information leaflets. We then make a plan. Our plan involves an antenatal plan, a delivery plan, and a postnatal plan. In our antenatal plan, we're thinking about whether this patient should be managed in our hospital or could be managed in a local hospital. Lots of things to come into play. The risk, as I said, the individual circumstance of the patient's distance between our hospital and where the patient resides. We try and optimize all conditions for delivery, including treating anemia, giving steroids if we're planning for an early delivery. And if the patient is not going to be admitted in hospital, which is the case in most of our patients, we then give them information about safety netting and the numbers to call and what to do in case of an emergency. There's a lot of planning that goes into delivery as well, starting from the operative plan. And although the risk modeling is still far from complete, but I agree completely with what Walid was saying, that attempting to deliver every placenta is extremely high risk. The best outcomes are those for conservation when conservation is achievable. The worst outcomes are those for an emergency hysterectomy. At least that's what the evidence and my experience suggests. We plan for the team necessary to be present. What equipment would we need? What time do we need, and when should a patient be admitted before an operation? This is part of our planning for delivery. We usually aim to have a half-day list. That's about 4 hours that to allow for the anesthetic and recovery time as well. And we at least aim to have the basic of 2 experienced surgeons and others from surgical specialties as needed, 2 consultant anesthetists, 2 anesthetic assistants, 2 scrub practitioners, a midwife, and a neonatal consultant. As governance is a hot topic, and I'm aware about all the discussions about governance in Egypt as well, we ask our patients to go through and read and sign a consent form, which is specialized and standardized for placenta accreta. We found out that the standard cesarean section consent form did not capture all the risks. And this is a consent form that is based on the real risks of placenta accreta. The patients are given a copy as well. The next set of slides will be from pictures from our setup. So we operate on our patients in Lloyd Davis position, and that allows us to collect the vaginal blood loss as well. And we sometimes use vaginal cell salvage. We use 2 cell salvage machines and sometimes even 3. All the swabs that Walid was showing, that because we have the facilities to use them for reinfusing autotransfusion, so we have a separate bowl for the swab wash where we wash those swabs and we use the blood to reinfuse the patient. A very important piece of equipment is the rapid infuser that costs 30,000 sterlings and is very important as it's a lifesaver when it comes to autotransfusion. On the day of the operation, we go through our final checklist to make sure that we haven't forgotten anything and that the blood is present in the fridge that is near our operating theaters. So we've got all the names of the other surgical members of the team and the support team should we need them. This is a picture from one of the patients that we operated upon. We warn our patients that there'll be lots of people in theatre and it could be very noisy. We've done half of our patients awake and half of them asleep. We usually do a combined spinal epidural, even if we're going for a general anesthesia for pain relief post-operative. We document all our ongoing blood loss on a standard postpartum hemorrhage performer that allows us to capture the blood loss live, as well as prompts us to treatment should we have forgotten them. And that's completely understandable that in the midst of the situation that things could be forgotten. So we try and have those prompts. For this first patient, and because of the persistent cervical shortening, I think the cervix was measured at 19 millimeters at one point. We planned for an elective delivery at 33 weeks. She received steroids and had a transverse malar incision with a planned hysterectomy. and a 3-liter blood loss. She didn't receive any blood products as we were able to autotransfuse her or what she needed. Interestingly, and that's an important point from an ethical point of view, is the baby was delivered in a hypotonic state. And that is something to consider, that when planning for hysterectomies, that the outcome might not be favorable from a baby's condition that is beyond our control. This baby had, sadly, a genetic condition. We use 4 pages to document our operative details, and that allows for accurate documentation of all surgical techniques that were attempted or done during the operation. It also allows, as you can see from the last page there, post-operative planning. The patients, in the post-operative plan, we focus on the immediate care, and most of our patients end up receiving level 2 HDU care, which is sort of a middle grade between ITU and standard care. There is then, when they are discharged from HDU care, which we are able to provide on site, they receive standard postnatal care, and the baby receives ongoing care. We see all our patients for a debrief appointment in 3 months. Our specialist midwife has been phenomenal in offering our patients emotional support that is much needed, as this is a scary condition to face. And as it is important, as part of the UK, the cervical screening program, pap smear test. So we inform the GPs if we've removed the whole cervix to remove the patients from the smear program. As I said, we aim to see all our patients in a debrief appointment. Again, this is documented in a performer where we go through their journey again. We explained what happened. We asked them about their experience, and we asked for their consent to be further contacted for research and surveys. As part of our governance, we're meant to present the data of all our patients in a 3-monthly meeting locally, as well as annually in the PAS Summit. And that allows for governance and comparison between and learning between different teams. This is something, again, as Walid was saying, that potentially could aid in learning for different teams in Egypt. I don't know if I've overran. Sharif, should we go through patient 2 or jump straight to conclusions?
We've slightly overrun, yes.
Okay, so I'm just going to go to conclusions then. So my key message is, again, as panelists, we've all agreed that the main focus is patient safety. This is not a one-man show, and the importance of the whole team cannot be overstated. To help funnel and build expertise, centers of excellence are needed, and actually research suggests that there is an 18-fold reduction in mortality and morbidity in patients managed in centers of excellence. It's very important to plan and not, you've got months ahead to plan and to have your operative plan and contingency plans. It's important to communicate your plan with the patient and know about their experience as well. This is indeed an emotional journey for the patients, and it's key to appreciate that and to offer them the correct support. And as a last point, I think our understanding of Placenta Accreta is developing, and there's lots of research that is needed for proper risk modeling to know which patients will be suitable for what surgical plans, especially differentiating between conservative patients suitable for conservative management and those who will need a hysterectomy. Thank you so much.
Thank you very much, Mr. Odevi. I think we'll get back to you on a lot of questions, but that will be later on. Moving on to Professor Ahmed Hussein. He will be our last panelist. It's a pleasure to have him with us. He's a professor of obstetrics and gynecology at Cairo University. Over the past 10 years, he's had a special interest in high-risk pregnancy, especially when it comes to obstetric hemorrhage. He has focused his efforts over the past 5 years in how to reduce maternal mortality and morbidity for placenta accreta spectrum and complex C-sections. Also, he has more than 30 publications over the past 3 years addressing these topics. It's a pleasure to have him with us, and I'm looking forward to your presentation.
Thank you so much, Sharif, and the organizing committee of the Egyptian Representative Committee of the Royal College for inviting me to this very important webinar. And I have been listening carefully to my colleagues, Professor Walid Bassiouni and Dr. Hudaybi. And I think that I explain a lot about the scheme of what we need to do for reducing maternal mortality and morbidity for such cases. And I will try to be a little bit more practical for the people, because people want to know what to do. So at the beginning, all the people knows about the placenta accreta as an obstetric nightmare, as Walid had told the story, and because of their maternal morbidities. And I will stop on the massive hemorrhage. The problem with hemorrhage in placenta accreta is not about the amount of blood loss, but again, about the rate of blood loss. So you can be an obstetrician who will have a case diagnosed by placenta accreta, you prepare 20, 30 units of blood, but if you don't know what you need to do for the patients, you may lose the patient, because even if you have 20 units of blood, maybe the rate of blood loss will be much, much more higher than the rate of transfusion replacement, and you lose the patient. And that's why people consider it as an obstetric nightmare. So what challenges that we have in low middle income countries? Unfortunately, these are the countries that have the higher number of cases, and they have these following challenges. We have a poor antenatal care program in most of the low middle income countries, and sometimes the patient's diagnosed while in labor or the attack of bleeding. We have high number of cases due to high number of C-section, few tertiary centers, so less experienced people. And we have low resources, sometimes no available blood, sometimes no available equipments, as cell salvage and stuff like that. But again, also, high-income countries have problems, because the problem in high-income countries, they have all the resources, but because they have few number of cases, they lack the training. And that's why in a lot of high-income countries, they hire a gynecologist to perform an obstetrician job. But unfortunately, this is not a sustainable system, because some centers are closed in different countries because when the gyne-onc in these centers refuse to do such cases. And sometimes the anesthesiologist of the gyne-onc refused to put these patients into sleep because he has a high operative list or a high number of cases for gyne-onc. And that's why if the gyne-onc refused to perform this procedure, the center is closed. So we need to know how we can train people to perform such surgeries. So I will tell you the story over the past 10 years and how we evolved in our management of such a condition. 2013, in our university hospital, Cairo University Hospital, we had a high-risk pregnancy unit where all the cases were transferred into it. And by that time, I was the most junior consultant, and they tell me that I'll be responsible for such cases. So I can describe all my feelings the night before the procedure by one word, which is insomnia. And why I had insomnia every night when we had a case of placenta accreta? Because I don't know the outcome. I don't know whether the patients will live or die, whether the patients will have massive hemorrhage or not, whether the patients will have bladder injury or not, whether the patients had ureteric injury or not, because of the following. We don't have a proper diagnosis. And the problem by that time is that the patient was sent to the sonographer. He got us a piece of paper telling us a case of placenta previa, most probably placenta accreta, or placenta accreta cannot be excluded, or placenta accreta is one of the diagnoses. We don't have a clear surgical plan, what we'll do next day. And we had by that time lack of experience because it was an evolving disease and we didn't do so much in our training. So in 2015, the European Working Group of AIP tried as much as they can by that time to put a standardized ultrasound criteria for the disease, which by that time was named abnormally invasive placenta. And they put it in a 2-day grayscale and color Doppler, which all the people knows about the loss of clear zone, abnormal placental lecany, bladder wall interruption, myometrial thinning, placental bulge, and uterovesical hypervascularity, subplacental hypervascularity, bridging vessels, and placenta lecany with Lacuni feeding vessels. And if you can see that this was an editorial, this was not based on research. This was a group of people that met together and tried to find a way. Yes, it was by that time tried to do standardization for these criteria, but this was not validated at that time. And then we come to the year 2018, when we had the FIG classification, which unfortunately still used till today, which classified the placenta accreta spectrum into either abnormally adherent placenta or abnormally invasive placenta, and which is placenta accreta, the abnormally adherent, and abnormally invasive placenta, which is placenta accreta and placenta accreta. And they describe placenta accreta as the chorionic villi traverses the myometrium but not reaching the serosa, and placenta accreta as chorionic villi pass away the serosal surface to invade the nearby structure. But the problem is that starting that time, 2018, we shifted from an era of underdiagnosis to an era of overdiagnosis. And these two papers were responsible for this shift and were responsible for the massive publications about cases of the degree of invasion related to the degree of severity and stuff like that. And the problem was with overdiagnosis is two things. Number one, the unindicated hysterectomy, and especially in the United States and other high-income countries, because when they have the report of the ultrasound based on these criteria as placenta accreta spectrum, then they go directly to an hysterectomy, even if the case is false positive. So the rate of unindicated hysterectomy for cases that not having placenta accreta increases so much, but this is not the issue. The problem was trying to do conservative management of non-pass case, and the surgeon think that he's good in doing a transparency surgery, and when he find the real case, try to do the same technique, then he's facing a big problem, which may lead to maternal, not only morbidity, but mortality. So in 2019, we had this case, and this was the beginning of what we've been doing over the past 6 years. This case was diagnosed as placenta accreta by ultrasound, referred to our unit to do the surgery. I performed the surgery. What I've did is that I opened the abdomen because the case was diagnosed as placenta accreta. So I did the midline incision, and there was time that we're doing by that time. And then I started to sec the bladder, and I exposed the lower segment. And I've seen people inside the room telling each other that this, according to fecal classification, this case of placenta accreta, and most probably we'll do an hysterectomy for her. And people around the room, they're seeing what we will do for this case of placenta accreta. So when I exposed the whole disease segment, I found a healthy myometrium at the upper edge of the placenta, and I found a healthy myometrium in the cervix. So what I did is that I opened at the upper edge of the placenta and then get the baby out. The placenta was this very, very thin stretch myometrium come out smoothly, and then I closed the uterus in 2 layers. So I tried to convince the people who were in the room watching me, and I am the chief surgeon. They're telling me, good job, you did a conservative management of placenta accreta. And I told them, no, it was not the case, because the placenta was separated from the lower segment. And what I did is, yes, a difficult procedure, but this was not a placenta accreta, because when I get the baby out, the placenta was separated, and I closed the uterus in 2 layers. So we had a problem with the classification, and I had a problem with communication with people, because if I am the surgeon, can't let the people believe in what I'm doing, then great, we have a problem. So we add this patient to one of our publications 6 years ago in 2019, but at that time, we don't have an evidence of what we're doing. So we mentioned it in one statement that there is a case of placenta previa with uterine wall dehiscence of the lower segment that may resemble placenta accreta. And imagine that there is no placenta here, and we put the head of the baby, and this happened to a lot of obstetricians when they open the abdomen, and then when they find the uterus, and they find a very thin myometrium, that they can see the head of the baby and the sac surrounding it just because of uterine wall dehiscence. If you remove this head and add the placenta, this will be the image. And I'm telling you, 80% of the papers in the literature have images of such cases and representing for the authors as a case of placenta accreta. So to improve our proper surgical management, we need to have a proper prenatal prediction surgical planning. And to increase the sensitivity of proper prenatal prediction surgical planning, we need to better understand the disease. And we cannot understand the disease unless we have a proper pathological diagnosis that make us better understanding the disease, so that we have a proper prenatal prediction and surgical planning. So we worked hard with a group of colleagues from around the globe over the past 5 years, trying to better understand the disease. And I will give you a very short summary about the keynote findings of these publications. Number one, placenta accreta is not a diagnosis. It's the name of the family, and we must know which family member we're dealing with. The second thing if the placenta totally separated, regardless what ultrasound signs that you have, regardless what intraoperative images by naked eye you see, if it totally separated, then you don't have Acrreta. And if you don't have a wall, you don't have a Acrreta, because by definition, which was set by the FIGO, but people misunderstood it, you need to have a wall, and you need to have a chorionic villi that traverse this whole wall to be outside the serosal surface. So if this wall is replaced by very thin fibrous capsule or very thin wall with dehiscence, and you don't have any wall, then you don't have the Acrreta. The third thing, there's nothing called the focal partial total Acrreta. And in 500 specimens over the past 6 years in my center and other centers in the world, the area of abnormal attachment of the placenta never exceed 30% of the placental volume. And in 80% of the cases, the area of normal attachment, true attachment, is less than 2 to 3 centimeters. So there's nothing called focal and partial and total. And this is very important in your management, because when you started doing hysterectomy to start getting baby out, you must be aware of vaginal bleeding, because sometimes part of the placenta may separate because the placenta is not totally adherent to the uterine wall. And which is new for most of the people, that abnormal placental attachment occur yet secondary to uterine scarification remodeling, and it's not a true placental disease. It occurs secondary to uterine scarification remodeling, and we will not tackle this issue right now. And again, PASS is not a sonographic diagnosis. You can just say high or low probability, because this is a clinical pathological diagnosis, and you can say by ultrasound only whether it is a high or low probability. So we try to validate the ultrasound signs, which was published in 2015, and we try to see, when we have a proper pathological diagnosis of all cases, whether these signs are accurate or not. And then we find that a lot of signs are present with what's so-called uterine scarification and remodeling rather than true placenta Acrreta. So this is an example. If you have a very thin wall from repeat cesarean section and uterine scarring, then definitely you will have loss of sonolucent zone, and you have a myometrium less than 1 millimeter, and you will have a placental bulge because there is no supporting wall to the uterus, and you will have sometimes blood wall interruption because of the fibrosis is not clear. So as you can see, most of these signs are not truly related to placenta Acrreta, but related to what's so-called uterine wall dehiscence, remodeling, and scarification. And at that time, this is not called placenta Acrreta, it's called placenta previa uterine wall dehiscence. And if you do it, yes, it's a difficult surgery. No one can ever argue about it, but you can't call it placenta Acrreta. And unfortunately, part of the rise in the number of the cases because people are mentioned all these cases as placenta Acrreta. So we tried to put all our opinion in 2 expert opinions that we have published previously, and stating the conclusion. It's not game of invasion anymore. It's game of placenta localization, vascularity, and adhesions. Don't think about the invasion as invasion, because this word sometimes make you furious, make you anxious. It's a game of placenta localization, vascularity, and adhesions. And this is the most important thing to improve the clinical outcome. So let's shift to the clinical part of the presentation, what we need to do. So I tried to sum up all the plan of surgeries in one slide. And before you go to the procedure, you need to have a plan. So you need to choose one from each column. What type of surgery I'm going to perform? Is it radical or conservative? What type of surgery, radical supracervical or total, conservative placental in situ, or uterine sparing surgery? What type of skin incision, a midline transverse? What type of uterine incision away from the placenta, at the upper edge of the placenta to the placenta? Why I'm going to do bladder dissection before the fetus or after the fetus. So if you don't have a plan before doing the surgery, then please don't do the surgery. But the real question is when to choose what. And this was the question that we tried to answer over the past 6 years, because the answer of this question depends on 3 factors. Number 1 is the patient's difficulty. Number 2, the surgeon experience. And number 3, the availability of the resources. And I will try to explain what do I mean by this. So you can have the patient with the same difficulty with 2 surgeons. One of them has a lot of experience and one of them has less experience. So the one with less experience, when he see these cases, he can say, have the safely procedure, I will go for midline incision, get the baby out from a separate incision from the placenta, and do hysterectomy. And the other one who is experienced with the same patient's difficulty will say, no, I will go for finished steel incision, I will take the bladder first, get the baby out, and then I will do refashioning of the uterus, control the bleeding, and do transplant surgery. So there is nothing called best option for the patient. Every patient has an individualized plan. But again, this individualized plan must not be outside this plan of surgery. You need to choose according to the patient's difficulty, your experience, and the availability of resources. And sometimes, maybe the patient's difficult, the surgeon is of a great experience, but he was called at 3 a.m. at night in the morning with no available resource in the emergency unit, and there is no blood, enough blood, so he will go for the less bloody procedure for him. Maybe the less bloody for him is the transplant surgery, maybe the less bloody for him is the hysterectomy, but he needs to choose one according to these factors. So this will take us to the next question. Why do we need an ultrasound? Because people do the scan at 20 weeks in the UK and United States to say high, low probability of pass. And then they do perform another scan to confirm whether high or low probability of pass. But again, pass is not the sole determinant of surgical difficulty. So when you do the scan, you need to answer the following questions. Number one, whether there's a normal placental attachment or not. And this is the question of high or low probability of pass. But you need to answer also the following. Whether this patient can do transplant surgery or not, what type of skin incision I'm going to do, what type of uterine incision I'm going to do, what is the risk of bleeding for such a lady, and what is the risk of injury to pelvic organs. So over the past years, we have tried to put a model to assess the surgical difficulty of the patients. And 6 months ago, in one of our publications, we tried to show this model. And it depends on very few factors that I hope that people can understand well. Number one, it's called placenta localization. So both of these cases, by definition, which is set either by the Royal College or the American College, are called placenta previa complete centralis because both of them have covered the internal os. So the sonographer will write the report of both of these cases are placenta previa complete centralis. Yes, this is the anatomical diagnosis of the two cases, but there's a totally surgical difference between them because in the one on the right side, the posterior compartment of the lower segment is empty. So in such a lady, when you get the baby out, you have the Douglas pouch, which is empty. The posterior compartment of the pelvis is empty. You can put your finger. You can do, if you have bleeding, you can do compression. The incidence of uteric injury is less because the placenta is not deeply impacting the pelvis. The placenta is not bulging in the pelvis. So uteric injury is less. The control of bleeding is better. And the exposure of the posterior and lateral aspect of the pelvis is much more easier. But the other one, when the placenta is totally filled, the lower uterine segment, the anterior and posterior compartment, then this surgery is much more difficult than the other one. So with both of them, anatomically are placenta previa complete centralis, yet surgically they're a little bit different. So if you are not experienced on the patient on the left side, you better to go for midline exposing incision because this lady had few cesarean section before maybe, and you don't have to have two risks for the patients, one of the intra-abdominal adhesion and the other one is the bleeding from the placenta. So if not well experienced, you can save the patient only by have a good exposing incision. But on the right side, when you know that the placenta is not filling the posterior compartment of the pelvis and it's not that low, then you have be more confident in performing the transverse incision. The next one is what's called vascularity across the placental bladder interface. Maybe when you do the color Doppler, you have a singular vessel, then in such a case, you can get the communicating vessel, and then you can have a proper dissection of the bladder wall if you have a defined bladder wall. But sometimes you have a bizarre multiple rows of vessel between the placenta and the bladder that you cannot demarcate the wall of the uterus between the placenta and the bladder. And in such a case, when you see such a thing, no, if I'm not experienced, I'll not go even for the surgery. And if I'm not experienced, I had to do an emergency, I'll get the baby out from separate incision, and then I will send the patient to a tertiary center. But if you face such a thing with a high vascularity between the placenta and the bladder, and you're not experienced and try to do such a surgery, then you know what's going on. And sometimes when you don't have a clear demarcation at that time, maybe, and you try to do the surgery, you can have an intentional cystostomy to demarcate the posterior wall of the bladder to avoid multiple injury of the posterior wall of the bladder and the trigone. At the same time, you need to keep the placenta intact inside the very thin wall and to avoid its rupture and crack to avoid massive hemorrhage in the field. The third one is what's called subplacental hypervascularity. And now I'm just mentioning the clinical significance of each side. So in such a lady, on the left-hand side, and you see that this case of placenta previa, maybe with some sort of signs of Acrreta, I don't care about it, but I want to do a trainees surgery. But in such a case, when you have a high vascularity in the placental bed, you know that if the placenta is separated, if you do manual separation of the placenta, you are subjected to massive hemorrhage from placental bed near the cervix. So what you need to do is that you need to do proper devascularization before either attempt to separation of the placenta or after immediate separation of the placenta. So you need to expose well the lateral side wall of the uterus. You need to put a plan of doing uterine either arterial ligation. You need to put a proper plan if you have bleeding vessels from the bed, if you do compression sutures, but don't get your hand and separate the placenta with this massive placental bed vessels without having a proper plan. And the other side, if you have such a high vascularity and you want to perform an hysterectomy, you can go for a subtotal hysterectomy for such a lady, because if you put your clamps here, then again, you may have bleeding from below the clamps and you have intractable pelvic hemorrhage. So in such cases, you need to go for a total hysterectomy. And this is what most of the people in the literature put it as cervical invasion. No, this is not what's called cervical invasion. This is what's called cervical hypervascularity. It doesn't matter to me what you will call it, but what matters to me, if you try to attempt to separate this placenta without having proper exposure and proper devascularization, the patient will die. And again, if you try to put your clamps here just below the placenta, you will have a massive hemorrhage in the pelvis. So in such a case, if you are not able to control the bleeding and you will go for hysterectomy, you need to go for a total rather than subtotal hysterectomy. And also, when you do a scan, you need to go to the lateral side walls. You need to see whether you have a wall on the lateral side walls. You need to have whether you have high vascularity in the both ligament or not, because this may affect your decision whether to do the surgery or not, or affect your decision how to perform the surgery. And then we'll come, because Dr. Hudaybi asked a very important question about what is the factors that we need to improve our decision on whether to do hysterectomy or trainees surgery. And I think one of the most important things is the presence of the myometrium in the lower trine segment. So in such a case, we have, this is the cervix, this is the external os, this is the internal os. And some people, when do the scan for such ladies, they say either the placenta is invading the cervix, or they say that the placenta is reaching the vagina, but this is not the case. If we turn back to 10 minutes ago, when we say that if you have a very thin wall due to dehiscence from repeat cesarean section, then there is no wall to support the placenta, and the placenta will bulge anteriorly to the bladder. And this is a defect in the uterine wall where the placenta just bulge anteriorly. So in the ultrasound image, it appears that the lower edge of the placenta is at the level of the external os. But if you can see the procedure itself, this is the placenta. As you can see, we can't see the cervix because the placenta by its weight is protruding anteriorly, but here is the cervix. So this is the image clearly you saw in the ultrasound because the placenta by its weight just bulged anteriorly. So in one of our recent publications, like 1.5 years ago, about the role of transvaginal scan in evaluation the risk of placental spectrum, we find that both the transabdominal scan and the transvaginal scan have the same sensitivity in diagnosis of placenta spectrum. But the transvaginal scan has 5 more sensitivity in diagnosing in prediction which patient will do a uterine surgery and which patient will do an hysterectomy. And this due to the presence of the myometrium in the lower part of the uterine segment. So if you have a myometrium near the cervix of 1.5 centimeter length and 0.5 centimeter width, then this is a good candidate to perform a uterine surgery. But if you don't find any myometrium to the cervix and the area of defect is more than 9 centimeters and reaches the cervix, then your success rate of doing a uterine surgery will be decreased. And the problem with these publications is that the maternal-fetal specialists in the UK and the United States, they're not trained to perform anatomy of the pelvis during the transvaginal scan. This is not the training program. They can do cervical length for assessment of preterm labor, but they need to improve their training in the maternal-fetal specialist to perform a transvaginal scan for such ladies to assess the vascularity and to assess the myometrium length and thickness near the cervix. So there are two ladies. When you open the abdomen, sometimes you find them both. Maybe the one on the left side is easier and the one on the right side is not that difficult. So let's talk about which ultrasound signs when you see is much more important to you. So we'll start with the lady on the left. As you can see here, when we complete this section of the bladder, you find that the placenta is bulging through a very thin myometrium due to repeat zone section and dehiscence, and you can find a good myometrium in the lower uterine segment. And this is the ultrasound image of it. You can see if we talk to the criteria that you're using about thinning of the myometrium, yes, it's thin because of the repeat section and loss of sonolucent zone. There is no high vascularity. Doing transvaginal scan, you will find a good myometrium here in the cervix. And this lady was doing uterine sparing surgery, and this lady was not a placenta accreta, but it was a difficult surgery. When it comes to the other lady, when we open the abdomen here, before bladder dissection, here when we start bladder dissection, and as you can see, we did just very attempt to do bladder dissection, but the bladder was so adherent, as you can see. Looking to the images of the ultrasound, you can see high vascularity at the placental bladder interface, very high vascularity on the lateral wall. But what was surprising that when you go lateral, as you can see to the lateral walls, as if part of the placenta is herniating through a defect from the lateral wall of the uterus. And this is the importance of performing an ultrasound before doing the surgery, not only diagnose placenta accreta spectrum or not, as I tell you, it's about placenta localization, vascularity, and unfortunately the adhesions, which we cannot predict by ultrasound. So when we open the abdomen, as you can see, this we decided that this lady is not a candidate to do a conservative management. We'll go hysterectomy all the way, and we get the baby out from a separate stab. So we were not able to sect the bladder at the beginning, unfortunately. And when you get the baby out, here was the placenta herniating from the posterolateral aspect of the uterus. And when we open the broad ligament, this is not what so-called people are calling it broad ligamentary invasion or lateral sidewall invasion or invasion of the great vessel, stuff like that. The placenta is enclosed inside the uterus above the cervix. Yes, it was herniating with a lot of vessels, yet is enclosed inside the uterus. It was herniating through a defect. This defect from previous uterine rupture, this defect from the previous section with extensions, yet it is confined inside the uterus. And what is happening, and what the people are saying, that there is a lot of invasions outside the pelvis due to rough surgical manipulations. And when this placental thin wall ruptured with massive hemorrhage inside the pelvis, the surgery becomes hectic. People try to put hectic clamps. A lot of injuries happened, a lot of injuries to the urinary system and to the major vessels of the pelvis. So in one of our publications, in 2023, we stated the following: all the ladies have the right to have uterine sparing surgery, and hysterectomy should be limited only to two things: either failure of reconstruction or uncontrolled bleeding. And both these two factors depends on three things: the patient's difficulty, the surgeon experience, and the availability of resources. So there is nothing called one size fits all. You need to choose your surgical plan based on these three factors. So here you can see, this is the case of placenta accreta. We usually go for exposing the disease segment first, and then get the baby from an incision at the upper edge of the defect, and then resect this whole defect, and then close the uterus well. And this is the area where the placenta is added to the uterus. And this is another one with no invasion, with no placenta accreta, and we did the proper dissection of the placenta, but the area of loss of the uterine wall was so big anterior and laterally, then we know that we have a failure of reconstruction of such a lady, and this is not the right option for the lady, so we did an hysterectomy for her. So a lady with placenta accreta uterine sparing surgery and the lady with just uterine dehiscence and a defect in the uterine wall with an hysterectomy for her. And then let's move to another concept. And this lady was highlighted this concept for us, and the concept what the world will be doing over the next 5 years. So I did scan for this lady, and I told them, I don't think this is placenta accreta, but I think this is a case of placenta previa with uterine wall dehiscence, and it has a high vascularity at the bladder. But this lady had the contractions at night, and then she was transferred to our emergency unit. And they called me at 3 a.m. in the morning, and they told me that your diagnosis was wrong, and this was a case of placenta accreta. So I diagnosed this lady that there is no even placenta accreta, and there is no normal attachment, and they diagnosed her as placenta accreta when they opened her, and they did a hysterectomy for her. So what I told them that you have the uterus, I will send someone to try to separate the placenta, and then the placenta also is separated. So I didn't question that they did the best for the lady, and according to their experience and according to the ability of the resource at that time, this was the right decision for the lady. But how come that we have two diagnoses for such a lady on both ends of the spectrum? So there is nothing not going well. And that's why we think by that time that we need to move forward from the placenta accreta dilemma. We need to move forward from the placenta accreta, I think what's called fever that they had the people, to another thing that can define the surgical difficulty. Because again and again, placenta accreta spectrum is not the sole determinant of the surgical difficulty. You can have a placenta accreta attached to the upper part of the uterine segment that you can trim this part and then close the uterus, and then you are happy. And then you tell yourself you did the conservative management of placenta accreta spectrum and put it on your note. And then you can have the case of placenta previa with repeat cesarean section, where the placenta will totally separate, but the bed is highly vascular and the bladder is so adherent to a thin myometrium that you need to have a lot of time to do proper dissection of the lower segment, a lot of time to do devascularization, and this patient may lose much more blood than the case of placenta accreta in the upper part of the uterine segment. So we tried to move forward about leaving the placenta accreta spectrum in this issue to what's called complex cesarean section. And then we set surgical difficulty of placenta accreta spectrum and difficult cesarean section, complex cesarean section into level 1, 2, and 3. I will move forward. I know, Chief, I passed my time, just 2 minutes, because this will not only help the patients, will help the team to decide which level of training can perform which type of surgery. And again, this will have an impact on the obstetrician, on the hospital and the finance, on the patients, and on the training. And we work hard with the FIG committee on childbirth and postpartum hemorrhage. And you have a publication 2 weeks ago about, and this is free because this is an open access on the journal of the FIGO, about the surgical approach to reduce the risk of intraoperative complications, postpartum hemorrhage in the complex cesarean section, which placenta accreta is part of it. And again, intra-abdominal adhesions part of it, high vascularity across the placental myometrial bladder interfaces is part of it, and adhesions is part of it. So to sum up, we need to stop to search for more signs of placenta accreta because this is useless and ridiculous and it will not go anywhere and with no impact on clinical outcome. And we have one of our publications where we try to compare the signs to the clinical outcome, and we find that most of the signs are not related to the clinical outcome. We need to correlate ultrasound sign to the surgical difficulty, which is more valid to clinical outcome. And we start a series of publications about it, how to evaluate the bladder injury and what signs we can have it on the ultrasound to predict the incidence of bladder injury. Also, we need to integrate the ultrasound and intraoperative finding to decide which case will do transplant surgery or hysterectomy, and which case that will need to do an MDT. And also we have a series of publications about it. And this is the only way that we can achieve our goal, which is reducing maternal mortality and morbidity and help in training. So this will take us to our next step, which is the training. It's not about the webinars, it's not about the presentations, not about the meetings, it's about the training. But the problem is how to train people, because this is very important, because you have cases, but you have around the world cases that they don't find a proper tertiary center. So how we can help people in training? So we start doing this with the multiple countries, multiple centers in different countries, how to train them. So you can tell them concepts, how to properly do surgical risk assessment by ultrasound through an online training, but you can't do surgical training online. You need to have them on site to do a physical surgical training for a short period of time. And then Walid mentioned about the telemedicine, and we had two publications about it, how the use of telemedicine. You train them by ultrasound online, you get them for physical training, and then you follow up with them with telemedicine, you audit, debrief, and then you share with them their cases through telemedicine, and then you measure their outcome and how they improve in their clinical outcome. So at the end, I just want to tell you that every year in Cairo University, we do a workshop about cesarean section, where most of the world experts, they join us. And this time we'll have it on the 16th and 17th of September at Cairo University Hospital. And I'm sorry for being late in this presentation. In the end, I want to thank my team for their great support and my colleagues from different parts of the globe, where we worked together over the past 5 years trying to reduce maternal mortality and morbidity in a lot of countries. Thank you very much, and thank you, Sharif.
Thank you, dear Professor Ahmed. It was quite a captivating presentation, even if we did overrun just a slight bit. But we do have a few questions to ask. Starting off with Professor Walid. There were a few questions for you. So the first was there was a doctor who asked, he had 4 placenta accretas. 3 survived, but unfortunately 1 patient had profuse bleeding due to atony, although the same approach was adopted. His question is, should bimetrial syntocinon be given in the upper atonic part of the uterus?
Well, actually, intrabimetrial syntocinon is not a uniform procedure, and I personally did not try it before. And this is very important to emphasize on, that not all the patients are the same. Usually when we open a case and we say that this is the most difficult one we've faced, the following case is much more difficult. So hence there's no one case like another. And this is very clear by what he said, that there are 3 cases that went fine and 1 that was excessive bleeding. And so that's why you have to emphasize on the surgical skills. And I bet that this patient improved his surgical skills, that if he faced this patient another time, his improvement will be evident on the outcome of the patient.
Right. Another question was, what is the role of placenta resection in your practice?
Actually, it is the placenta resection, because we do conservative surgery, or one-step simple conservative surgery. We remove the placenta completely. We do not leave any placenta aside, because we find that leaving any placenta at site is a desperate measure, and you only do it if there's desperate times. So that's why we remove the placenta completely. We remove the parts that are adherent to the walls of the uterus, and we reconstruct the lower segment to properly close the uterus, as I showed in the pictures.
Okay, so another question, and this was actually from me. I'm sorry, I'm going to abuse my position here. How would you advise women regarding conception after conservative management?
Well, actually, accordingly, as I mentioned, the paper we did about 50 cases that we assessed intrauterine hysteroscopy, we found that there were no adhesions. And I personally have a bunch of ladies who, after a cesarean conservative surgery for placenta accreta, they got pregnant and we delivered them again. And actually, none of them were placenta accreta again.
Oh, okay. Thank you very much, Dr. Walid. So, Mr. Hudaybi, there are a few questions as well. Is there, so someone was asking if you've had prior experience with Jehovah's Witness regarding placenta accreta, where you can't give blood products in a situation where basically the lady's bleeding on table.
That is my nightmare, and I hope I never do. And I have a few Jehovah's Witness patients that I've dealt with, having been working in the UK, there is a liaison committee, and prior to the family events, and I was speaking to their leader of the group, the leader of the liaison committee, to organize a meeting with them. I think the short answer is no. the long answer is we have to respect patients' wishes, and if that's what they wish, then that's fine. It will be completely limiting into what we could do. Cell salvage will be very important, and we'll definitely use vaginal cell salvage in that situation. And then the ethical question is, if a patient who's a Jehovah's Witness asks for an elective cesarean section, how much information is out there to tell them that there is risk of a placenta accreta in a subsequent pregnancy? So no is the answer, but I wanted to elaborate on it a little bit.
Okay. And in your opinion, what's the best day to do a C-section for a PASS patient? Because you mentioned the first lady was at 33 weeks, but in general, what would your advice be?
We aim to do our patients. You see that there's a slide that Walid showed that's comparing various guidelines, and there's a paper on comparing various guidelines. And I think between 34 and 37 weeks, depending on the facilities and the availability of the team. Look, placenta accreta is a high risk, but that's only a risk. The danger actually starts with placental separation. The aim is to avoid a situation where you have partial placental separation. And if that means that you have evidence that this is going to happen, because there is evidence of preterm labor, there's shortening of the cervix, there's previous history, then that is more, you lean more towards an earlier delivery. But if not, then you weigh that against the complications of prematurity, including the long-term neurodiversity sequelae.
Right. Dr. Ahmed, I have a few questions for you, and then I'm going to come back to Professor Walid. So cesarean scar pregnancies could lead to PASS. If that is so, someone was asking if early management of cesarean section pregnancy could basically prevent PASS. And the other question is regarding techniques to separate the bladder with the least blood loss.
So I will answer the first question from two angles. The first angle is about our country and countries like ours. The problem is most of the ladies, when they have repeat cesarean section and they have more than one kid, they don't show early. So they usually come in the second half of pregnancy. So you will miss in country like Egypt, the cesarean scar pregnancy, and you'll find them as placenta accreta spectrum. So let's talk about the UK, because they have the best experience in this, and they have Davor Ikovic, who is one of the lead in the cesarean scar pregnancy. And he mentioned a lot of publications about in the cesarean scar pregnancy, you leave them because 50% of them will change into missed abortion. And in the other, when you do scan at 9-10 weeks and you find that they have cesarean scar pregnancy, you do surgical evacuation for them with a technique that I can't do it because I'm not experienced in it. And the problem is you need to do suction for them. You need to counsel the patient first. It's not your decision, it's their call, but you need to properly counsel them. But before counseling them, you need to do proper assessment whether this placenta will be implanted on this defective area or not. And they need to counsel the patient about the risks of having placenta accreta spectrum in the future versus the risk that you're going to do termination of the pregnancy. So this is a shared decision between you and the patient after taking care of the risks. But the problem in Egypt, because if we can see all these patients at the beginning, then we will not end up doing such a lot of complex cesarean section at the end. So the problem is we'll not see them. But if you see them very early, you need to counsel the patient, first assess the risk, and then counsel the patient, and then both of you will take a proper decision based on her opinion.
Right. And Professor Ahmed, being the lead surgeon, do you always do your scans before operating, or is it possible for someone else to do the scan? And then
this is the most important question. I'm not a maternal fetal specialist. I don't scan babies. I don't do the 20 weeks anomaly scan. I train to do the placental ultrasound. And I know this is not what the UK is doing because they need to go to a maternal fetal specialist. I know the UK system quite well. The problem is it's either the sonographer and the surgeon and the pathologist will meet together before the procedure intraoperatively, or they have a big problem. So we can do this in our country. So I train myself to do the placental ultrasound. And that's why I have 80% of my publications related to ultrasound, 20 of them related to the surgery, because I think after doing the surgery that the surgery represents 30% of the success. It's all about proper prediction and surgical planning. If you do one mistake in the surgery, it will lead to hell. If you see that this lady is properly for conservative, and then you go through the placenta, and then you find that this is not a proper candidate for the conservative, you will lose 5 liters of blood. So you can save the patient by proper planning. So either the sonographer, but the problem is in Egypt and a lot of low middle countries is that when the surgery went south, the surgeon will tell the sonographer this is a case of placenta accreta. So the problem that the sonographer, every time he sees the same images, will write the same report. And this is how it went viral in countries like Egypt, Turkey, Brazil, Argentina, stuff like that. Because they don't attend, they don't cooperate. The surgeon, because of his ego, will not say I did something wrong. He will tell the sonographer, yes, it was very difficult. And the sonographer, when he sees the same images, will write the same report again. And this happened a lot. So it's better either to do the scan or the sonographer and the surgeon will attend the scan and attend the procedure.
Right. So still NDT approach would probably be best for this. Professor, there are a few questions regarding devascularization, basically. So a few questions regarding internal iliac artery ligation, pre-delivery uterine artery ligation, whether you do preoperative or intraoperative, as in pre-delivery, sorry, or during the delivery itself of the baby. Embolization, does it have a role for morbidity? A tourniquet to devascularize the uterine arteries. What would be your approach regarding that?
As we said, the role of internal iliac artery ligation is now declining, because when you occlude the internal iliac artery, you're going to shift the blood through the external iliac and the posterior division of the internal iliac artery, and hence the new vascularized vessels are going to be more congested, and hence the bleeding is going to be much more. So internal iliac artery ligation is declining nowadays. The internal iliac artery balloon is also declining nowadays. I've attended one case of uterine artery embolization in a post cesarean case with bleeding, and it was successful because he ligated, or he occluded the uterine artery, and hence the uterine artery is the main bleeder. If you ligate it, I usually ligate it after delivery of the baby and before delivery of the placenta. Bilateral low uterine artery ligation, and this is very successful in decreasing the blood loss. But the internal iliac artery ligation or the internal iliac artery balloon is not beneficial nowadays. I also read a question about the cervical inversion. Written by Dr. Ihab Goma. I don't know if he's Dr. Ihab Goma, our professor in Ain Shams or not, but if he is in Kuwait, I hope he's doing fine. There's nothing called cervical inversion, because when we use the internal os of the cervix or the apparent part of the cervix to stop the bleeding, you do not invert it. You just hold it with Alice or bladder forceps and take hemostatic sutures in it in order to stop the bleeding, because the cervix, as Dr. Ahmed said, is never invaded by the placenta.
There's a question, I think this might be for Mr. Hudaybi, of a triple B procedure, if you have an opinion on that procedure.
Not particularly, I think. The idea of devascularization, I think I lean more towards what Professor Ahmed Hussein has been describing is as the surgical technique for conservation. The principles of a triple V you could apply, but it's more about the risk prediction. I don't think that I lean more towards the uterine artery ligation and the corporal uterine artery ligations, and doing a wedge resection if possible, not necessarily a triple V.
Okay. So I think we've had a few questions as well regarding conservation. So one of the questions was they wanted a bit of a more detailed approach to cervicoisthmic sutures regarding conservation in the cases of PASS. So what would your opinion be on something like this?
Is this question for me, Dr. Sharif, or Dr. Ahmed?
I think this was for you, for Professor.
Okay. Well, actually, it's not the cervicoischial sutures or the uterine cervix as a balloon tamponade. It's been discussed lots of times because you try to find a place where is tough enough in order to take the sutures in it. There's no lots of bleeding from it. And hence, this is the place you're going to try to stop the bleeders from the placenta, which was removed. And when you the pictures that Dr. Ahmed showed, where the placenta was dropping in front of the anterior fornix, actually, when you try to conserve it and remove the placenta, you're going to find a space which is welling with blood, and hence you have to close the space properly. And the anterior lip of the cervix from the inner part is the most strong place where you could take your stitches with least injury and with the strongest stitches that support the hemostasis. So that's why anteriorly and posteriorly, with ensuring that the patency of the cervix is still present.
Right. Dr. Ahmed, there's a question for you regarding ruptured uterus with the placenta accreta. I think it stems from the picture of the lateral border with the placenta, lateral wall of the uterus with the placenta coming out of it.
Yes, there was a publication from the Utah team in the United States, Brett Anderson and Robert Silver, about half of the cases of placenta accreta reported in the literature was a case of ruptured uterus. And the problem is, when I show you that a defect in the wall uterine dehiscence with a very, very thin wall where the placenta is implanted on it, the ladies start to have contractions. This very thin wall will crack, the placenta will bulge in the abdomen, and there will be intra-abdominal bleeding. So when they open the lady, they will say this is a case of placenta accreta because they will find the placenta in the abdomen with a massive hemorrhage, and the team is not experienced. So when it comes to contractions will lead to the ruptured uterus. And this will be the question of, again, when to terminate. Let's talk about the problem with the guidelines, okay? The guidelines is the guideline for the country where this guideline is set for. It's based on the demography, based on the number of cases, the resources, and their training. So and that's why last year we had publications about, it was very clear, are the international guidelines fit for low middle income countries or not? And we find that, yes, you can take part of this guideline, but again, you need to suit this guideline based on your resources and on your situation. When it comes to even the termination of pregnancy, which is very important, when to terminate, all the people say the guidelines say from 34 to 37, 34 to 37. Okay, so in a country like Egypt, you know how many places in the NICU are available? None. So you terminate at 34 weeks. So you will say to the lady, I will terminate for the maternal risk, but let's forget about the baby. So what we found that it's better about the timing of the termination, which is very important in countries like Egypt. It's less costly for the country and less costly for the patient to hospitalize it. Yeah, you cannot hospitalize it in the UK for 2 weeks, but you can hospitalize it in the Cairo University and in Shams University for 2 weeks. Because if it had an emergency, I had contractions or trigger of bleeding, and this patient is well diagnosed, well prepared, you will be transferred immediately, we'll do the procedure immediately. So we prefer, in most of the cases, rarely, the only cases that we terminate early is the cases presenting with hematuria, because this lady may lose a lot of blood. But in most of the cases, we do prefer to terminate even with PAS, with high vascularity and all that stuff, more than 36 to 37. We don't ever bypass 37 because the risk of contractions will be more, but we prefer to perform them. Yes, this is not the guideline of the UK and the guideline of the ECOG, but they have fewer number of cases with available NICU beds more. So again, I hate when you talk about the guidelines saying, because we cannot do and apply it in our country, because either we can apply the maternal safety first, but we need to modify it in a safe way to get the mother and the baby safe. So rupture uterus happened a lot. Happened if the lady was undiagnosed, happens if the lady didn't follow up, and happened if you leave the lady more outside the hospital, and which is 2 hours from any tertiary center. It may happen.
Okay. Thank you very much, Mr. Hudaybi. There were a couple of questions regarding who would you choose to conserve on? Is there an index, or is there a certain metric that you use to decide on who you want to, who would you prefer to conserve or not?
I think there are two aspects of this question. I agree with what Professor Ahmed's saying is, again, it depends on the facilities. So because we have the capabilities and we have the facilities, we have the personnel and the equipment, my choice of conservation might be applicable for the UK and might not be applicable for the rest of the centres. To answer that question, there are three components. The first is regarding the pathology itself. So it has to be a suitable pathology, i.e. the diseased area has to be a small area with adequate normal myometrium around it and accessible. Number two, it has to be the patient's wishes as well. We do not have, we have to be honest. So we have to say, we know that attempting conservation has two outcomes. One of them is really good, successful conservation, and one of them is really bad, an emergency hysterectomy. So it's a risk, and there is no solid data on which approach is suitable for which patients. And the third thing that would affect my decision, I think, will be other comorbidities as well, and other factors. So a patient who's had multiple cesarean sections in the past, has completed their family, a patient who has other pathology ongoing, a patient with a high BMI, all those things would factor in when it comes to thinking about which patient to conserve on. So the pathology, the patient's wishes, and the comorbidities will be the key factors for that.
Right. I think we're going to have to just go through the last few questions because we're kind of running out of time. Professor Ahmed, I have a quick question regarding the last sentence you said in your last answer. So you were saying if you found hematuria, you would prefer to deliver this lady early because she would be more likely to bleed. Would that be because you suspect Acrreta or invasion into the bladder?
So this is the question that I don't want to answer, because we had one of our publications was accepted 3 days ago we did a systematic review and a case report about hematuria. It was accepted in the American Journal 3 days ago. We reviewed the literature well over the past 40 years, all the published literature about the case of hematuria. None of them have the proof of bladder invasion. Hematuria does not mean bladder invasion because bladder invasion never exists at all. The problem with hematuria is the hypervascularity, not the invasion. I need people to focus about the complexity of the surgery rather than the word invasion. Hematuria happened from the high vascularity in the bladder wall, and these vessels sometimes may be subjected to minor trauma due to the rupture and leading to hematuria. And what is the commonest thing of the trauma is either the fetal kicks or the contractions. So with hematuria, it means bladder hypervascularity and hypervascularity in the interface rather than the invasion, because all the cases in the literature, when we reviewed them, they failed to show any signs either in the pathology of bladder invasion. And we combined them with cases that we did at Cairo University, and 3 of the cases of them, we have the bladder intact, and the 2 cases that we opened the bladder because there was a blood clot, no sign of placenta inside the bladder. So no, we do them earlier because the risk of bleeding, not bladder invasion, because cases with hematuria may go to an extreme attack that may lose 1 liter of blood in 10 minutes. And cases of hematuria have a high vascularity at the placental myometrium bladder interface, and these are very difficult. Even if they had contractions, we cannot send them to the emergency room to do it. They need the expert team, and sometimes when they have contractions and bleeding, even to assemble the expert team to come to the hospital, it may take 1 hour or more, and this may be not good for the patients. So in cases with hematuria, we prefer to do them early to avoid the risk of massive hemorrhage, not the bladder invasion.
Thank you very much, Professor Ahmed. Professor Walid, the last couple of questions are yours. Is he with us?
Yes.
Right. So someone was asking about packing during or after finishing the surgery to reduce the bleeding. And there was another question about whether a posterior placenta previa would be easier to manage than an anterior one. And the last one was about, well, let's answer those first and see how it goes.
Actually, usually I do not close the uterus until I'm sure, that's I will not say 100%, but at least 95% that there's no bleeding. So usually I don't need packing. When I need packing, that means I did not control the bleeding sufficiently, and hence this patient is going to bleed from sites I did not diagnose properly. And usually the patients who, after you finish the procedure and examine her vaginally, or if you put it in the Lloyd position as Dr. Hudaybi did, you find excessive bleeding coming down from the cervix. This means that you did not control the bleeding properly, and hence hysterectomy is a better procedure. So actually, to pack the patient, usually it's not a routine procedure. If it's a posterior placenta, yes, definitely it's much easier, but it's not that easy because bleeding from the posterior wall needs to be controlled properly, specifically if it was reaching the internal os or it's reaching the lower segment specifically, because that means that if you remove the placenta and you try to conserve the uterus without properly doing hemostasis to the bleeding surface, the patient's still going to bleed, and then you're going to face atony, and then you're going to face massive hemorrhage also. So yes, it's easier, but it's not that easy.
Thank you very much. I think that's it when it comes to the questions. Thank you very much to our esteemed panel for your participation. Unfortunately, Professor Yasser just texted me that he had to step out because of a incidentally placenta previa patient. He promised that he would do all the recommendations that you've said today. He would like to thank everyone for being here. It was a complete pleasure having each and every one of you, and we look forward to seeing you again. He would also like to remind everyone that our upcoming Royal College Egyptian Representative Committee meeting will be in September. We also have 2 webinars coming up regarding 2 very important topics. One of them is regarding FGM and adolescent gynecology, and the other one about fetal medicine. And we will be looking forward to seeing you all there, hopefully. And if you would like to know more about our courses, we would please want you to check our website and our YouTube channel, actually, for all the webinars that we've done so far. They're all there. Once again, thank you all for your valuable time today, and I wish you all have a very good night.
Thank you.
Thank you, Dr. Sharif, and thank you, Dr. Ahmed and Dr. Hudaybi. Thank you very much.
Thank you very much.
Thank you.